So I'm Katie. Most people fear death and dying. I actually fear public speaking. So this is pretty terrible for me personally. I was told that we were speaking to a nursing class. My manager didn't really inform us. So how many nursing majors are here, just out of curiosity? Awesome, one. So two. Okay, so we came with the intent of speaking to you from a nursing standpoint. So real quick, we're trying to change what we're going to say, tell you about what we do, and our goal is truly just to not bore the hell out of you. I promise we'll try and keep this quick, but just a little bit about what we do is we work on a palliative care unit. We work with patients who are dying for the most part. We have patients that come to us who are very sick. We try to manage their symptoms and get them home. We try to maximize their quality of life for as long as possible. So on our unit, we have 10 patients on a regular basis, and we just basically try to provide the best care that we can. So now, knowing that you're reading a book on empathy, there's a lot of things that we do that kind of personalize their care. Can you just tell them a little bit about just like how our hospice program?
We have two types of patients. We have palliative care patients, that's inpatient, and we also have hospice patients. The difference is palliative, you can still receive IVs, antibiotics, curative treatments, so it's not quite, you're done, you don't want nothing else. As opposed to hospice patients, they just don't want anything else left but comfort care. So we focus mostly on pain management and breathing. Those are the two things that they are really afraid of at the, when it's time. So you have to really get to know the patients. Each patient has a story to tell, and we love to find out who this person is that's laying in the bed. And it's not just that, the family also really needs us. They're at a loss. They don't know what's going on. They don't know why this is happening. And so what we do, we try to kind of step by step help them get through it. There are family members who are on board, who understand what's going on. There are some family who are angry and refuse to accept palliative care. And there are some family members who just don't want to give up. So we have to kind of work with them and try to figure out what we need to do to get them to understand that this is what their loved one wants. A lot of them have wishes, and family members are going against their wishes, and so we have a lot of conflict going on our floor. But at the end, I have to say that we do a pretty good job trying to get everyone on the same page. But it's not as easy as everyone thinks it is. It's very emotional.
Yeah,
would you say?
It can be very emotional.
Very emotional, and you get to be very personal with a lot of them. We try not to, but there are some times we do get a little too close, and we too cry. But we just don't cry in front of the family. We just cry behind the
I cry in front of the family. But it's not always that easy.
It's not. So we're going to start with some PowerPoints and just kind of give you a brief idea of what we do on our floor, and then from there we'll tell you what's next. Okay.
Just to touch on a few things that Shirley said, as far as hospice and palliative care, a lot of people think that they're the same thing. Hospice is a term that defines a patient who has a life expectancy of 6 months or less. So you can be on, and oftentimes we find that our hospice patients will outlive hospice, and they have to renew that hospice benefit, because essentially what it comes down to is money, insurance reimbursement, and that benefit being extended. And then Shirley mentioned something also about personalizing care. Our goal is, patient comes into our unit, we want to find out as much information as possible about a patient. We encourage them, first off, we want to know culture, religion. We want to know, their family, where they are. Are they the matriarch of this family? Are they one of 13 siblings? We want to know what it is. We ask them to bring pictures in. How can we learn more about their life? Not only for us to know how we can care for them, but it also acts as like it's a journey for the families to take when you're experiencing the death of a loved one. There's this journey that you need to take to get there, and allowing them to have these pictures, to talk about their loved one, or if there's music playing that acts as it's just try to incorporate all of those things just to help.
It kind of helps them their anxiety level too. So they get to be a little bit more relaxed. They laugh a little bit. They're so tense about this whole thing. So by just talking to them, just being their friend, and just getting to know them, that helps. That really does help the family and the patient too as well.
Yeah, absolutely. All right.
So let's start with the PowerPoint.
You're up.
Palliative Care Unit. We have a 10-bedded unit. Okay, it's dedicated to care for patients with serious illnesses and their families. It's a specialized team that, of experts that provides treatment for pain and complex symptoms related to advanced illnesses. I have to say that we are 10-bedded. We're a very small unit. It's just, it was like a tryout kind of thing. They weren't sure if it was going to work. So we were one of the few nurses who decided, let's do this, and it blew up. And it blew up to a point where we have a waiting list of people waiting to come to our floor. But unfortunately, we only have 10 beds. Some patients do get a chance to come to our floor, and a lot of them don't get a chance. They pass away on the other floors before they even get to us. So we're constantly, the turnover is crazy. It's really crazy.
As far as us starting, when we started our palliative care unit, Shirley and I both were working as med-surg nurses, and I came as a travel nurse. Yeah. And I feel like this specialty kind of found us. So when we started it, we were only one of 3 palliative care units in the nation. And right now still there's probably only a handful of actual palliative care units. There's a lot of now consult teams. So palliative is a growing field for many reasons. Ethically, we're able just to care for patients better. Financially, cutting costs, medical costs at the end of life. There's a lot of good benefits from it. So we're happy to say that we're kind of pioneers in the
And we became a family care. Also. Yeah. You know, we won the Teamwork Award 2008, only after a year of opening. And it was such a big thing that we had newscasters come in to interview us. We had pictures taken of us. Other floors wanted to know how we did and what we did differently, that they wanted to also mimic us. We became a family. You know, I mean, it's just not just punching in and punching out. There's so many times that we're calling in our cars, like going home and saying, "Oh my God, I forgot to tell you this. Oh my God, who is it?" And we're always asking about, you know, patients. How is so and so? How is he doing? So we constantly are thinking about our patients, even though we're not at work. We are always talking about our patients and stuff like that. So.
Yeah,
nice.
And when it was started, it wasn't always that easy. When we started, I know for me personally, I had a very hard time with, why are we stopping tube feedings on a patient? How can we ethically stop tube feedings on a patient who maybe has no mental status, maybe is not awake, aware, anything? How can we ethically stop feeding? I'm a Catholic, how is this possible? And that evolved over time. You know, you start to really develop it because, you know, you have to just keep an open mind. And you know, you really start to think about what you would want for your quality of life, and you know, and those are all good discussions to have, even within each other, or you know, with your families. Everybody's entitled to their wishes and their wishes to be granted. You never know what can happen in life. So, I know I'm annoying to my parents. I know exactly what they want. My mom says I'll never let her go, but I'm telling you right now, I know exactly what my parents want. My sister, you know. You take care of the things that are important. So
that is also another challenge, because a lot of patients don't know or didn't tell their family members what their wishes are. So now we have to come up with what's best for the patient, try to explain that to the family. Some families are with it, some families are not, and then we have family fighting. So we have to deal with that too, in a professional way. You know, try to help them to understand this whole thing. So it is a lot. It is draining and it's very emotional. But it's also very rewarding, believe it or not. And it is true, when you're in nursing school, you're taught to advocate for your patients, fight for this, fight for that, fight for, you know, to keep them alive and well and send them home. In this case, it's the opposite. We have to fight now saying, this is not appropriate for this patient. The patient doesn't need to have 2 feedings and IVs. It's making it worse for them instead of better for them at this point. So it did take a while for me as well to reverse my thinking process, so you know, I can help my patients at the end of life. Okay, so we're going to go next.
Yeah, this here is just a list of who our team is. You guys can see this. Everybody's involved. This is from more of like a hospital medical standpoint, who's involved in our team. Nurses, managers, our physicians, respiratory, social work. Who's not included here, who's very important, is physical occupational therapy. So that, you know, it's really a team process just to get everybody going. For our team, our unit, like we said, unique, you know, compared to everywhere else in the hospital. We have daily, pretty much daily family meetings, rounds, where doctors and nurses are touching base with the family, making sure that the goals of care haven't changed for a patient. This just talks about our unit environment, which we're proud of. But
You're gonna.
What do we have here?
So we do take patients. Another thing that we're specializing in is ventilations. Patients are intubated, and that's another totally different thing too, because a lot of the patients need it in order to breathe, and then they either die on it, or family members during their meetings talk to the physicians and make that decision. Okay, where are we at here? And if there's no improvement, then they have to make that awful decision of terminating the patient off the vent, which is very emotional for them, as well as us too, but that's something else that we have to also deal with. So, you know.
Emotional, tough, yet very loving decision. To love somebody so much that you don't want them to suffer, to be able to remove a tube, which is very uncomfortable, is just, it's a loving decision.
Mm-hmm.
Oh,
Pet visits.
yeah, go ahead.
We're one of the only, I think we're the only floor who allow pets. We allow dogs on the floor. Whatever we think is going to help the family and the patient during their very last hours, weeks, months, whatever it may be, they can bring a pet from home. We also have pet therapy that comes and visits during the day. Now, I work the night shift, and she works the day shift. So there's a lot going on during the day, not so much going on during the night when it comes to pet visits and stuff like that. But that's one of the things that we do offer, which is kind of cool.
Actually, just last week, I have a little story. Just last week, we had a patient that came to us, a young patient, metastatic breast cancer, had a young son. She came to our unit, and I basically said, you know, hey, anything goes. Do you have any pets at home? Mm-hmm. She said, oh, I have a dog named Buddy. And I said, I said to her husband, why don't you bring Buddy up here? Patient, when she came to us, alert, oriented, just laughing, speaking, smiling, very happy, had been hospitalized for the past 2 months. They brought Buddy up. 3 hours later, the patient died. Unexpectedly. Expected because she had metastatic breast cancer. We knew that this would happen over time. Unexpectedly because your mental status doesn't change that quickly. For some reason, she was waiting to see this dog. I mean, it really, you know, I'm not a dog person, but I know people who are. It's a member of your family, and you know, and sometimes patients will hold on to that and wait for that last person to come and visit. And in her case, that was Buddy.
Right. We also allow them to have alcohol, beer, anything. Yeah. We have orders, yes, give it to the patient, swab it in their mouth. If they can drink, let them swallow it. We have that too. So again, we're the only floor who can do those things. Yes.
Yeah.
How come you're allowed to have alcohol?
Because this is it. They're gonna die. Whatever they want, whatever we give, you know, as long as it doesn't really interfere with hospital policies and stuff, but
yeah, that goes along with us trying to do anything we possibly can. We had a gentleman with us for a couple of months who, for Valentine's Day, all he wanted to do was have a Valentine's Day dinner for his wife. So we have a VIP section of our hospital that we can pretty much coordinate anything. So he ordered a dinner, planned a nice little candlelight dinner, one of the electric candles, and they wheeled down with a nice little silver platter, and they brought down a dinner. So when his wife came by after work, they could have a Valentine's Day dinner together. You know, him on his medication, on his drip, he can't leave the hospital. You know, they were able to have something like that. So, you know, just as that part of empathy, it's just, you know, God, we have the ability as just human beings just to spread kindness, and that's just, you know, that was just one thing that we were able to do, you know, for them.
we had a mother who every year, always celebrate one of her kids' birthday. She would decorate the kitchen with everything, birthday cake, everything. But it turned out that she was hospitalized. She couldn't be there at home to wake up and celebrate her son's birthday. So we went beyond, and you started it actually. You made it so that she was able to have a pass to go home, decorate the kitchen, have the happy birthday, blah, 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 and came back to the hospital. So we try.
Yeah, she actually came home. She was able to come home that morning. Before her son walked down the stairs, she was sitting there waiting to have their breakfast, their birthday breakfast. Husband had decorated the house, and during that time, she had two older daughters. Her son had just turned 12, but they're two teenage daughters. She gave out her jewelry to them, and it was kind of like her final goodbye in her home. And 3 days later, she died, but she had that closure with her family.
Right.
And it was cool. Honestly, we have the best job in the world. We really do. We have such an opportunity to make a difference, and caring for people who are dying is like the greatest privilege.
Yeah, it is.
So, I mean, You know, we stand before you and we tell you these sad stories, but truly we're so privileged to have the opportunity to care for people.
We had another patient who wanted to have a goodbye farewell party. So she invited all her immediate family, whoever wanted to come. They had pizza, they were laughing, joking, all in her room. That was her final goodbye. And after that, she didn't want no one coming anymore. And then I think she died a few days after that. So she wanted to say goodbye. And that's the way she wanted to do it.
Yeah.
These are very touching stories. And speaking of which, are you at the LIJ near Ronald McDonald? I volunteer there.
Oh, really? No, we're at North Shore, which is in Manhasset, so we're right on the other side. But we have our physicians practice over there as a consult team. But yeah, and they're very involved with Cohen's, right?
Yes.
Yeah, that's great. It's a great organization to be a part of. Yeah, I'm telling you, volunteers, and that was on our list of important people on our team, right? We have our volunteers on here. Yeah, trained volunteers. I mean, our volunteers are what help our unit to go. We have this lovely gospel singer. He sits on our bench and he just sings. Nobody pays attention, but they do. Everybody just kind of goes on with their business, and he just comes up. He has this beautiful, soulful voice, and he just sings, and it's
nice.
So our volunteers are huge. So thank you. All right, what else do we have here? Bereavement support. We work very closely with Hospice Care Network. Like I said before, it's just really a change in benefit, but they provide bereavement support after, for the loved ones who have lost a loved one. Let's see. These are just examples of type of patients that we get on our unit. We find that we have a lot of oncology, a lot of cancer patients, a lot of stroke patients.
Now I have to tell you, everyone that comes to us is not at the point of dying. We do have a lot of patients too who just need management, pain management, anything that will give them that chance to go back home, have a nice normal life. We do that too. So a lot of people think that it's just patients that are just ready to just die. It's not true. We do have a lot of other patients too that do leave and go back home or nursing home, somewhere like that. Who else?
Palliative consult. If you ever have a loved one in the hospital and you feel that they're in need of palliative care, you don't need a doctor, a nurse, anybody to call. Actually, families can call palliative consult. It doesn't mean, there's a lot of myths to palliative care. A lot of people think we euthanize our patients. They come to us, they must be a DNR, do not resuscitate. So there are a lot of myths that, we kind of got a bad rap, but, anybody is eligible for palliative care. Any age, any stage of illness. We're really just, like we said, here to provide the quality of life for as long as possible. Let's see, care.
It's all about living as well as you can, as long as you can. That's our goal.
Deserves palliative care. We said
Anybody,
anybody,
terminally
any
ill,
age.
those expecting fully recover or facing years with debilitating symptoms from chronic progression of disease. Benefits, fewer trips to the hospital, decreased medical costs, improved quality of life, prolonged survival of terminal illness. So, we try our best. Sometimes we can't, this is it, and we let them know. We let the family know, so whoever wants to be there has an opportunity to be there.
Yeah, this is a big one here. Fewer trips to the hospital. Anything is possible at home. If you have a loved one you want to bring home, anything can be made possible. We've brought patients home on ventilators, removed the endotracheal tube at home so that they're taking their last breaths at home. It all depends on, family wishes, goals of care. That's why all those discussions
We had a
are
family
really
that
important.
wanted to go back to her country. And we did everything possible to make that happen. That wasn't easy, but she did. But she passed away on the plane.
Yeah.
So she didn't really quite make it there, but
she did make it there.
Well,
She did make it there with her son by
but she
her
was
side.
happy.
Yeah.
That's what she wanted.
Myths about palliative care. Yep, that's pretty much what we. Morphine drips, which is also untrue. Most people think of morphine and they think that it hastens things. What I try to tell people is, and I truly believe this, if somebody's coming onto our unit and they're working really hard, their heart is working really hard, their heart is going to tire out way faster than if we put them on a morphine drip and make them comfortable. So when you see morphine, don't necessarily think, oh my God, they're dying right away. Morphine actually slows down the process and just makes them more comfortable. We have other treatments. We have patients on dialysis, radiation. We do palliative radiation where maybe it's not going to be curative, but it'll help with pain. We've definitely done surgeries on our unit, feeding tube placements, still other barriers, huge barriers, physician attitudes towards palliative care.
Still a problem.
Yeah, it's still a problem. There's a very old school way of medicine. So it's just basically opening our minds and not inflicting your own beliefs onto your patients, because a lot of patients do feel differently these days. But we need to just goals of care discussion, families. We got what's important. This is all relatively.
So after talking to them, 95% of them respond to it. They understand it now. It's word of mouth. It's explaining what we do and taking out that negative idea about what palliative care is all about. It is a nice thing to have an option, especially when you're at that point, to know that there are things that can be done to help you to live a better life as long as you can. It's hard, but once you get over that anger and you start to accept, and we can help make it better for you guys. Hospice care continues the goal of palliative medicine outside the hospital. We do have a lot of hospice patients. We also, I forgot to say that, we have a certain beds that we have to keep open for community patients who are hospice at home, who may need to come in for managing their pain or something like that temporarily. So we do have to keep a bed open for that reason. So they come in, they get their treatment, they get whatever they need done, and then they are subject to, go back home to their regular lives again. So, the doctors.
Nurses care. Okay. There's no trivia here. Okay. A couple of things, unique to our unit. We have, when we talk about, our research projects.
Yeah,
we have a couple of research projects that we've started about 5-6 years ago or so. We found a funny little, almost looked like a pressure ulcer on somebody's backside that we were like, what is this?
That?
It's different than anything we've ever seen. And lo and behold, death occurred within 24 hours.
Yeah.
And we're like, what was that? Documented it, measured it, wrote the color, everything down. Started happening a lot. So our unit found something that's now widely published, which is a terminal tissue injury. So now we've been given, everybody has that $1 million question, how long and when, So I feel like we finally have a way to give somewhat of an answer if we're given this indicator. It's not always, but it's, families want to know, when's it going to happen? I have family out of town, we don't have that
Should they come in?
crystal ball. We don't know, but now we kind of have a little bit of an edge. And then our other study, the olive oil.
Yes.
We've done.
Olive oil, it helps a lot with their oral mucous membrane being dry from breathing through their mouths and stuff. So that was also another study that we also created and found and very helpful for our patients. As opposed to that, we also give them Robenol, which is a medication that helps stop the secretions, because a lot of times the muscles, they get weak, and so they start collect secretions in the back of their throat. That sounds very horrible for the family members. They think that they're choking. And so we have medication that also can help with that. We try not to suction them too much because that's irritating to the back of their throat. A lot of them don't like it either. So we do have other ways to, help ease the problem, make it easier for the patient to breathe and things like that. Is there anything else?
Yeah. And, other religious, cultural considerations, just some examples of what we do on our unit. For Catholic patients, we have priests available. We have chaplains pretty much for all religions. For Catholic patients, they have priests that come, sacrament of the sick, last rites. I've had Buddhist patients who, when they die, they're to be as close to the ground as possible. So we have lowered patients to the floor after they have died, just to be as close. Granted, we're still on the 4th floor, but it's somewhat symbolic. For our Muslim patients, facing Mecca, so we know the position of the bed and where it needs to be. For our Jewish patients, rabbis are very involved in our goals of care discussion. Certain things they can and can't do, and that's a very big supporter for them. As far as care after the patient dies too. So those are some important things. Some other things that we do on the unit, we do handprints, for loved ones. So just so they have handprints maybe for their grandchildren or their children, or a baby that's to be born. A couple weeks ago, we had a daughter who was losing her father on our unit, pregnant with her first baby. So our ultrasound team came in and did a sonogram at the bedside so he could hear his grandchild's heartbeat before he died. So all these things are just possible for us. We talked about pet therapy, pictures, music. We have a nurse's aide that was working in our hospital. Our hospital paid for her to go back to school and get her cosmetology degree. So now she goes around and she does hair and nails and makeup, and just to make people feel better, especially on our unit, it's important. There's so little that you can control when you're dying, and that's, nails. We do nails on our unit. I have my nursing student here, Dara. She's currently learning all the things that we do, but nails is something that we do too. There's nothing that we don't or can't do.
Because we have patients that are as young as 25 with cancer, and on our floor, and up to 103. So
yeah, we have all walks of life.
Ages.
Just this past Christmas, I took my 22-year-old down to the gift shop to go Christmas shopping. I mean, there's nothing that we can and won't do, and honestly, there's nothing I won't do. I'll put my job on the line if it means making somebody happy in the end of life. We'll find a way. Our administrators are so supportive. Whatever you need, getting patients outside, whatever it takes. It's just really important for us.
I had a patient who just had another granddaughter born while she was on our floor, so we made sure that she had visiting rights to leave the floor to go visit her granddaughter, who was just born like 2 days ago.
Yeah.
So it's nice. It is nice. It is also sad, and but again, like I said, it's very rewarding too. It's a different type of nursing, that's for sure, but I don't regret it.
No, definitely
I've done
not.
it all, but this is the end of the rope for me. This is it.
Yeah.
After 22 years of so many different aspects of nursing, this is definitely the one I like the most. Yes.
You both have experiences in other units, and I'm wondering what led you to be interested and so involved in palliative care, and what type of training is involved.
Yeah.
It's weird. I've been a nurse for 22 years. Okay, yeah, so I've done this, I've been that, I'm bored. After 6 months, I gotta do something else. So I go to this, I do outpatient dialysis, I wanna do MICU, I'm all over the place. And then I decided to leave. Moved back to Chicago, where I was born and raised, and I don't know, I think it's God. He sent me back home for a reason. I didn't know at the time. When I got there, everything's fine. My sister started having some problems with, coughing, pneumonia, bronchitis, blah, blah, blah. To make a long story short, she winds up finding out she had lung cancer. So I'm like, great. It's different when you're taking care of someone else with cancer, but now I'm on the other side. Now I have a loved one who has cancer now. So I took it upon myself. I made sure she went to all her doctor visits, all her radiations, all her chemos. She moved in with me. I took care of her from the moment we found out until she died, in my house, in my room, next to me. It was 8 months of taking care of her. I'm very happy and proud to be a nurse, and I was happy to be there for her. It wasn't too bad for me because that's what I do, but at the same time, now I get to really know how it is on the other side, because I was a family member going through it. She wound up having hospice, but I pretty much took over. So there was not much they could do. I had everything under control. I cut my hours from work. I was there. I had coverage 24/24 between me and the other family members. So, and then the last thing she told me before she died was, I don't belong here. I need to go back to New York, back to palliative care. That's where I belong. And I kept that promise, and I moved back to New York, to the same floor, to my same shift, for the third time. So I think I belong there. It's just me. Every time I would go away, I find myself coming right back to the same floor, same thing. So I think that's my calling. And my sister helped me see that. Yeah.
Yeah, I think the same thing. You know, I didn't choose palliative care. I don't think there are many people out there that have that, you know, morbid mindset where they want to go somewhere where there are people that are dying. But like I said, I was a travel nurse. I was out in Hawaii. I was in California. I was doing a travel assignment in an overflow unit that was looking to hire nurses. So our unit became palliative care. And as far as our training goes, you know, we both have our nursing degrees, and you know, with a nursing degree, you can really the beauty of nursing. Not that we're promoting nursing, but at least for the 2 nursing students, you know what? You can work anywhere. You know, pediatrics, geriatrics, critical care, end of life. You know, there's really anything that we could do, and for us, you know, this seems right. And there are certain, you know, we have our certifications in palliative and hospice care, so it just specializes it a little bit. And you know, there's a course, actually, a great course that we took, LNEC. Yeah, and we have a little exercise. Does everybody have paper and a pen where they could write some things down? We have a little exercise to do. This is from an LNEC course that I took, and this is just to help you to kind of understand. We're just going to try and get you thinking about death and dying. If at any point anybody is uncomfortable with anything, you know, feel free to not participate in the exercise or to step out. It's just for just to get your mind thinking.
I'm going to need to have you write down 5 most prized possessions, material things. 5 most prized possessions. Anything. Material things, non-material things, 5 most prized possessions.
Oh, let me see.
This material things?
Yeah, it'll be something material, but not people. That'll come next. Right?
Yeah.
Yeah. Okay.
Okay. The next thing I want you guys to write down is your 5 favorite activities. I like the next one. Okay, next we're going to do 5 most valuable body parts. What's valuable for you? Can you exit me out of that? Okay, next one. I want you guys to list 5 values that are important to you. 5 values that are important to you. And the last part is name 5 people whom you love the most. Yes.
Is it 5 specific people?
Yeah.
Like names?
Yeah. That's fine, and this will only be for you to see, so. This is where it gets hard. Where do you draw the line at 5, right? It's hard. Nobody else has to see it either. You don't have to bring it home with you.
I have to tell you, the reason why I'm doing this is because she gets too emotional and she can't do it, so I had to do
Yeah.
it.
Typical.
Okay, so you got all that written down. The next thing I need you to do is, as I tell you the story, I need you to cross out as many items on your list as I talk to you, okay? Imagine it is a lovely spring day. You know the kind, one of the first days when the snow has melted, the flowers are blooming up, north or down. Here, the temperature is comfortable and the birds are singing. You are young and successful and happy with your life. You step in the shower, anxious to get on with the day. While you soap yourself, you discovered a small lump on your neck and another one in your breast. Cross out 2 items. So it's a normal day. Everything is working.
So this
fine.
is just a little scenario that's
Scenario.
guiding through. You're starting your day. You can put yourself in this situation. You're starting your
Imagine you're in
day.
the shower.
You get in the shower and you notice a lump on your neck and in your breast. And you know, men and women can have breast cancer. This is where this scenario is going to lead you. So for this first part, now you're just going to cross out 2 items that are on your list. Anywhere on your list from any of those 5 categories or 4 categories.
Okay, so you say, okay, probably a swollen gland from your recent cold, you think, and you ignore it and you go on with your life. 2.5 weeks later, it is still there. Cross out 2 more items. Now you're saying, okay, probably it's a cold returning and you've been busy, not resting. So you've had a cystic breast. You're rationalizing that, right? Life goes on, but something keeps nagging at you, so you make an appointment to see the doctor. Cross out 1 item. The doctor, after examining you and ordering a mammogram, says, I'm sure it's nothing, but I'd like to biopsy it just in case. So we'll schedule you for surgery the end of the week. Cross out 3 items. So now you decide to have the biopsy and to go ahead with a mastectomy if the lump is malignant. Malignant meaning it, everything is, you sure it's not nothing, it's just malignant. It's not tumor, it's not cancerous. You're just gonna go ahead and have the mastectomy done. Cross out 2 items. Now you pull your way up through the fog in the recovery room and feel the mass of bandages on your chest. Your worst fears have been confirmed. Cross out 4 items. You recover and have radiation treatment, just in case. Cross out 2 more items. Slowly you recover your strength and life returns to normal almost. It is spring again, 2 years later. You have a cold. You ignore it as usual, but it doesn't go away. One morning, to your surprise, you find it difficult to breathe. Cross out 2 items. Lung metastasis. You feel your world turn upside down. That wonderful defense mechanism of denial must be let go. You begin chemotherapy and are very sick, weak and angry. You lash out at your family, the doctors, and friends. You want to live, but you cannot eat. Cross out 2 items. One morning, you do not have enough energy to sit up in the chair. The doctor tells you the chemotherapy is not working and he wants to stop it. Cross out 3 items. It seems like life goes on around you in slow motion. Days and nights blur. How odd, you think, staring at your bony hands as your body deteriorates. Your spirit seems to be withdrawing also. You wonder if it is the pain medication or if it is the first taste of death. But you do not have the energy to ask anyone. Cross out the last 2 items.
So this here is a journey that one goes through, from diagnosis until the dying process, and we get to see that firsthand. And little by little, they lose their independence, they lose control over everything in their lives, and it breaks our hearts. And we're privileged that we get to be with them in the end of their life, but we're also privileged because it makes us realize what we have, and to appreciate life more and to not take things for granted. So this necessarily isn't just to make everybody feel sad and depressed. This is just empathy. This is understanding what people go through and knowing that, maybe your kindness, creativity, anything that you can do for those around you can really just help this process.
Life is short. So take every minute of it and enjoy it and appreciate it, because you never know when it's going to be your last. We had a patient that was driving to work. She had a severe headache as she was driving, so she was smart enough to pull over. By the time she called her son, who called 911, she went up on our floor and she died a few days after. She had a massive bleed in her brain while she was driving. So she woke up fine, but she never saw home again. We could tell you all kinds of stories, good ones and bad ones, but I see life differently now. We have this opportunity to enjoy life. So we complain about the cold, we complain about the snow, but that's nothing. Life is so important. And just hugging and kissing and saying to someone, I love you, is important too, because a lot of them don't get a chance to say that. So I just want you guys to know that's what we do. That's what we love to do. Yeah. And if you guys have any questions for us, we're happy to answer some for you.
Did we depress everybody? It's like...
On the
Yes.
Have you ever dealt with a patient with ALS?
Yes. We have
Yeah,
ALS.
actually, just the other day I had a patient with ALS. It's unfortunately become a very common diagnosis on our unit, and it's really tough because inside you're all here, and your body just giving up on you.
Right, it's tough.
So we recently had, and the family said, the patient was on a continuous BiPAP, so it's not like a ventilator, but it's something that's supporting their breathing enough. And the family said, can he go outside? He's 68 years old. Can we get him outside? And sure enough, we did. And it's important that just life wishes.
Is North Shore the largest chain?
North Shore is
We pretty much got
of the
whole
health
Long
system.
Island,
Yeah, we dominate that.
We
Yeah,
got
the health system
16 to 17 hospitals now.
Yeah.
And now they're crossing over to Connecticut and Jersey.
Yeah.
Yeah.
Yeah. But a lot of awareness, right, this past year with ALS, the Ice Bucket Challenge and all of that. So, it's good for us because, knowing how we're seeing those patients on our floor, that there's a lot of money being put into research. So hopefully one day we'll see a cure for that. But,
If any of our students are touched by what you've been sharing with us today, and I'm sure that they are, but they have no desire to go into nursing, is there something else that you could recommend that they do that's related to nursing where they could be of service to others?
just existing. You can exude empathy and kindness wherever you are. Friends, family, complete strangers. It's really anything. If you have a desire and interest in end-of-life care, you can volunteer at any hospice facility. We have volunteers who just volunteer to bring people, family members, back and forth from hospice facilities, just to help out patients. If they live in the city and and they're at a hospice facility out on the island, they're always welcoming volunteers, fundraisers, be part of. There's a ton of things you can do around death and dying, but any profession in general, I feel like any profession, you have an opportunity.
Yeah, volunteer. Just make yourself available if you want. Just be nice. You never know.
Are there any other questions or comments from the audience? Well, please join me in thanking our guest speakers.
Thank you all. Just make sure you leave here today and just tell those that you love them.
Yeah.
If you love them. I mean, I guess you have to love them, but yeah.
Ladies, thank you very much from the bottom of my heart. As I've said, that I do know these ladies personally. Excuse me. Thank you. I do know these ladies personally, and this is what you've shared with us today, I think is extremely valuable. You need to really think outside of yourselves. Empathy, put yourself in someone else's shoes. These women do it every day. So I think we should try to be more like you. So thank you so much.
Thank you.